Portal hypertension is defined as sustained elevation of portal pressure more than 12 millimeters of mercury. Normal portal pressure is 8 to 12 millimeters of mercury. It can also be defined by a portal pressure which is higher than 5 millimeters of mercury above the normal level. Normally, portal vein carries 75% of blood flow to the liver with all nutrients to maintain its integrity, and it gives 50% of oxygen to the liver. Hepatic artery carries 25% of hepatic blood flow and gives 50% of oxygen supplied to the liver. So, as you can see, portal vein being the most important blood flow in channel for the liver. Left-sided portal hypertension, which is also called as Sinister portal hypertension, can be caused by isolated splenic vein thrombosis, which is often caused by adjacent pancreatitis or neoplasm. A rise in portal pressure stimulates portosystemic circulation. So whenever there is rise in portal pressure, the collaterals develop. Portal hypertension causes compensatory portosystemic venous collateral formation. It alters intrahepatic circulation and increases splanchnic blood flow. So there is fine vasomotor regulation between hepatic inflow and outflow. So whenever the liver senses that it has got decreased blood flow due to portal hypertension or any of the pathology in the liver, compensatory there will be increase in splanchnic circulation. So there will be increase in blood supply to the liver. High pressure in the portal system. High pressure portal blood is diverted via coronary, that is left gastric vein, short gastric and esophageal veins into azygous venous system. There is increased portal resistance and increased portal blood flow. Increased resistance can be pre-sinusoidal, sinusoidal and post-sinusoidal. So if this is liver, this is portal vein, this is hepatic artery, this is splenic vein, this is superior mesenteric vein, inferior mesenteric vein, and this is spleen. So portal venous circulation can be explained by this simple diagram. So whenever there is raised portal pressure, so whenever there is associated pathology in the liver, the causes of which we will see in the later, there will be increased splanchnic circulation by increasing the blood flow in the splanchnic system. So this will automatically increase the blood flow in the portal system. So the pressure in the portal system will rise. Suppose if there is an obstruction here, so pressure in system will increase. So whenever there is pressure increase in system, it will obviously try to go away from different channels. So there will be collaterals at various places. So increasing resistance can be pre-sinusoidal over here, sinusoidal in the liver, or post-sinusoidal after the liver. So we will see causes of pre-sinusoidal. Pre-sinusoidal can be extrahepatic here, or they can be intrahepatic before the sinusoidal forms. So extrahepatic can be portal vein or splenic vein thrombosis. So obstruction over here or here, which is the most common cause for portal hypertension. Then there can be intrahepatic before the sinusoidals form. It can be schistosomiasis, which is the most common, and sarcoidosis. Sinusoidal, where the hepatic sinusoidals are there. Sinusoidals can be represented by sinusoidals cause as cirrhosis, hematomal cirrhosis, hemochromatosis, Wilson disease, congenital hepatic fibrosis. So congenital hepatic fibrosis, hemochromatosis will cause portal hypertension due to sinusoidal involvement. So there will be deposition of fibrous substance in the space of Disse, leading to the portal hypertension. Post-sinusoidal can be at this level. It can be because of Budd-Chiari syndrome, obstruction of hepatic veins, or congestive heart failure, which will form a back pressure. In Western country, more than 90% of cases of cirrhosis, in Western country, more than 90% of the cases, cirrhosis is the cause. In India, extrahepatic portal vein obstruction, 33% is the cause, and extrahepatic periportal fibrosis, which will form 33% of the cases. This is becoming more common. As liver is normal in these conditions, patients get better care by shunt surgeries. So when your liver is normal, there is abnormality only in this system. If you can divert this system to other side by shunt surgery, patients get better survival rate. Now we'll see what are the sites of portosystemic anastomosis. So whenever there is rise in portal pressure, obviously blood tries to find its way out to other system in the systemic circulation. So these are called as sites of portosystemic collateral. It can be lower end of esophagus. So whenever there is portal hypertension, the veins draining, it is called as left gastric vein. So it will try to release this pressure at lower end of esophagus is the left gastric vein, which will form collaterals with the azygous vein. So lower end of esophagus, there will be collateralization between left gastric and short gastric veins and azygous vein, resulting in esophageal varices, so which is the most common site for porta-systemic collateral formation. At the umbilicus between paraumbilical vein and anterior abdominal vein, at the umbilicus between paraumbilical vein and anterior abdominal vein, resulting in caput medici. So there will be collateral between paraumbilical vein and veins of the anterior abdominal wall, which are the part of systemic circulation, and there will be formation of caput medusae. Other sites for porta-systemic collateralization are lower end of rectum between superior hemorrhoidal vein and inferior and middle hemorrhoidal vein, resulting in hemorrhoids. There can be collaterals at retroperitoneum, which is called as veins of Retzius. There can be collaterals at the bare area of the liver. So bare area of the liver, which will be in contact with the diaphragm, they can directly form collaterals between portal and systemic component. So what are the presentations of the portal hypertension? The triad of portal hypertension is formed by esophageal varices, splenomegaly and ascites. So if you are asked a question, which of the following does not form the triad of portal hypertension? They may add a few additional things like jaundice or coagulopathy or encephalopathy. Only these, if they are present, they form triad for portal hypertension. They are esophageal varices, splenomegaly and ascites. Patient can be presenting with jaundice, features of encephalopathy, coagulopathy and hepatorenal syndrome. Patients presenting with portal hypertension, they may be investigated for liver function test, ultrasound of the abdomen, which will document status of the liver, how is the echo texture, how much severity is the cirrhosis. They will also tell you the Doppler findings with the portal flow, where there is hepatopetal or there is hepatofugal. You may investigate with alpha-fetoprotein and Child-Pugh score system. Nowadays, MELD model is model for end-stage liver disease, which is assessed by specific equation using creatinine and bilirubin. So patients who are for liver transplant, they are given priority on the basis of MELD system. Serological assessment for serum ion studies, alpha-1 antitrypsin deficiency, that is ceruloplasmin, along with autoantibodies investigation for hepatitis can be done. Doppler imaging is done to see vascular pattern, direction of blood flow and size of the vein. CT scan and MRI is done for the cause, finding the liver cirrhosis. CT scan will also show sites for porta-systemic collateral formation and liver nodules, or if malignancy if it is present. Nowadays, hepatic venous pressure gradient, that is HVPG, it is done using a balloon catheter. The difference between free hepatic vein pressure and wedged hepatic vein pressure is called as hepatic venous pressure gradient. If it is more than 10 millimeters, it is indicative of cirrhosis and portal hypertension. It is important measurement because a gradient in excess of 10 millimeters of mercury is necessary for varices to form, and a pressure gradient more than 12 millimeters of mercury is required for varices to bleed. So this is very important point. You may be asked question, if pressure gradient is more than 10/8, then the varices are likely to bleed. So they may ask you to find out the proper pressure. Upper gastrointestinal endoscopy is diagnostic for the varices. So it should be done in every case of portal hypertension to know varices are formed or not, or if there is presence of portal gastropathy. Liver biopsy is done to find out the cause for liver cirrhosis. Endosonography can be done for the complications of portal hypertension or varices like stricture esophagus, or where there is erythema or thickening at the lower end of esophagus. Splenoportography earlier, which is done to assess the venous anatomy of the portal system, now it is being replaced by triple phase CT scan or MRI venography of the abdominal vessels. How do you manage portal hypertension? There can be general measures like anemia correction, nutrition supplementation, vitamin K supplementation. There can be specific measures for treatment for varices, for hepatic encephalopathy prevention. There can be specific measures for treatment for ascites, along with measures to be taken for reduction in the portal pressure. Now we'll see what are the surgeries for portosystemic shunt. These are selective and non-selective. There can be drugs to reduce portal pressure like propranolol, nadolol, isosorbate 5-mononitrate, which will reduce the portal pressure. We can also do liver transplantation. Esophageal varices, when they are formed, they can be asymptomatic. They may present with hematemesis, melena, or as a recurrent bleeding. Varices begin to bleed when portal pressure exceeds 12 mm of mercury. When present with severe hematemesis, patient shows features of shock, so patient may bleed to death. Mortality in bleeding is around 25 to 30%. Factors related to variceal bleed are portal venous pressure, gastroesophageal reflux causing ulceration, variceal size, and variceal wall tension. So this is very important point. You may be asked which of the following may not relate to variceal bleeding. So predictors for variceal bleeding are portal venous pressure, gastroesophageal reflux causing ulceration, variceal size, and variceal wall tension. What are the types of varices? Esophageal varices and gastric varices. Esophageal varices, which are in the lower one-third of the esophagus, usually 3 or more in number. They can be graded as level 1, 2, 3 and 4 based on gastroscopic findings, or they can be gastric varices which are fundal or in upper part of stomach. Classification for gastric varices is extension of esophageal varices. They can be extension of esophageal varices. So esophageal varices, same, they will come in the stomach to form gastric varices. They can be present in the lesser curvature or at the fundus. So they can be present in the lesser curvature or they can be at the fundus. There can be isolated gastric varices which are common in fundus. So you may be asked question, isolated gastric varices are common in which places? Fundus, lesser curvature, greater curvature, or at the body. So they are common at fundus. In other parts like stomach and duodenum, which are body or antrum, they are rare. How do you investigate with varices? Endoscopy is the choice of investigation. Grade 1 is minimal varices without luminal prolapse. Grade 2 is moderate varices with luminal prolapse with minimal obscuring of gastroesophageal junction. Grade 3 is large varices with luminal prolapse and with moderate obscuration of esophagogastric junction. Grade 4 is very large varices with luminal prolapse and with complete obscuring of gastroesophageal junction. We may see cherry red spots which may be sign of impending rupture. Endoscopic sclerotherapy or variceal band ligation should be tried in acute bleed also. So when a patient has got acute bleed, the endoscopic variceal band ligation or sclerotherapy can be done. If facility for sclerotherapy are not available or sclerotherapy or banding fails or it is not possible due to massive bleed, then balloon tamponade can be done. Once acute bleed stops, patient is investigated further by liver biopsy and superior mesenteric or celiac angiography or MR angiogram. Cuvelier-Baumgarten syndrome, it is loud venous hum heard at the umbilicus in case of portal hypertension. So whenever there is collateral formation between portosystemic collaterals at the umbilicus, there will be Cuvelier-Baumgarten syndrome. Ultrasonography of the abdomen is seen in cases of esophageal varices to see for liver and portal vein. Size of more than 13 mm is quite significant for bleeding to occur. How do you treat esophageal varices? So there will be two parts. The treatment prior to esophageal variceal bleed. So patients who are not bled and patients who have bled. So in short, it will be the treatment for portal hypertension. So treatment of varices prior to bleed with no history of earlier variceal bleed, that is for primary prophylaxis. So we have drugs like propranolol, which will reduce the portal pressure by 20% with pulse rate below 55 per minute, or it will reduce the pulse by 25% of resting pulse. Nadolol, which is long acting, less lipophilic, which is not metabolized by the liver. Isosorbate mononitrate can also be used. Drugs reduce rebleeding by 40%. Endotherapy can be also done for patients whose varices are likely to bleed. So, treatment of varices after one or more episodes of bleeding, which is for secondary prophylaxis, we have endotherapy, shunt surgeries, and drugs like propranolol. So treatment for varices is considered in two headings like emergency management of bleeding varices and definitive management of varices. So whenever there is bleeding, you have to resuscitate patient and manage acutely to reduce the bleeding, and once the bleeding is controlled, these patients are subjected for definitive management that they should not further rebleed. So what is emergency management? You should controlling the acute bleeding. Initial important measures are volume and electrolyte correction, central line placement and maintenance of central venous pressure, blood and blood product supplementation, antibiotics should be given, and encephalopathy is prevented by various measures. We have got pharmacotherapy, endoscopic banding and sclerotherapy, balloon tamponade and intrahepatic shunt, along with emergency devascularization surgical procedures. So we'll see how do you prevent or how do you manage acute bleed in cases of variceal hematemesis. Drugs which are used are vasopressin 20 units in 100 ml of 5% dextrose in 20 minutes is given, followed by injection vasopressin 0.4 units per minute for 24 hours infusion. Vasopressin is contraindicated in ischemic heart disease as it causes coronary vasoconstriction. Nitroglycerin prevents coronary vasoconstriction and hence it also be used as it reduces portal pressure. Vasopressin causes fluid retention and hyponatremia. Terlipressin is better than vasopressin. It has got longer half-life with fewer side effects. Somatostatin, it has got half-life of 2 minutes. Somatostatin does not cause systemic vasoconstriction like vasopressin, but it reduces the splanchnic hepatic blood flow. It is given as continuous IV infusion of 250 micrograms per hour after an initial bolus of 250 micrograms. Octreotide now is the drug of choice for half-life of 2 hours. It is to be given 50 microgram bolus and 50 microgram hour. It is given by 50 micrograms IV bolus and 50 micrograms per hour for 5 days. So octreotide nowadays is being used because it is cheaper and it has got less side effects and it is easily available. Vasopressin may be more potent for treatment, but octreotide is more commonly used. Propranolol will decrease portal pressure. It is used at later period for prophylaxis to prevent bleeding. Nadolol is also used, which has got longer half-life. You should be giving proton pump inhibitors also to prevent gastropathy. Endoscopic therapy is done by banding or variceal injection, which is by sclerosants or by glue. They can be used to control acute bleed also. Endoscopic variceal banding, it is done for esophageal varices. It is not commonly done for gastric varices as banding is difficult in retroflex position. So you may be asked a question, banding is done for which type of varices? Esophageal or gastric varices, or they may add other questions, but it is ideally done for esophageal varices. It is gold standard for esophageal varices. Banded varices thrombose and they slough off, leaving small discrete ulcers. It controls bleeding in 90% of the cases. So it's technically easier, chances of rebleeding are less, and complications like perforation or stricture are less. So if you are given which is the choice of treatment for acute variceal bleeding, the first is pharmacotherapy. If the pharmacotherapy doesn't control, then you have to resort to various endoscopic means by sclerotherapy or banding. So choice of bleeding in acute variceal bleed is pharmacotherapy. Now we have got endoscopic sclerotherapy. Endoscopic sclerotherapy is commonly used. It is technically easier and cheaper. Both intravariceal and paravaricial or only intravariceal injections can be given. Sclerosants used are ethanoamylate oleate, sodium morate, sodium tetradecyl sulfate and polidocanol. Complications of sclerotherapy, they are fever, retrosternal pain, massive bleed, perforation, mediastinosis, stricture esophagus. Sclerotherapy is done weekly for 6 to 8 sessions until varices are obliterated. Later follow-up endoscopy is done once in 3 months for 6 months, once in 6 months for 2 years and then year for lifetime. So you may be asked question, so if the patient of sclerotherapy, what is the level for follow-up? So they may be giving various options. After 1 year, how should we follow? Sclerotherapy will cause 70 to 80% of bleeding, but rate of rebleed is higher than banding. So in acute variceal bleed, when pharmacotherapy fails, the banding is preferred to sclerotherapy. So tissue adhesives can be used for endoscopic glue injection. It is commonly used for gastric varices. So gastric varices being high pressure system, glue is injected for gastric varices and not for esophageal varices. So N-butyl cyanoacrylate is used. It has got 90% success rate. Needle tip is placed correct in gastric varice and 1 ml of adhesive is injected. So there is chance of endoscope to get blocked. So whenever endoscopic therapy fails, balloon tamponade can be tried with Sangstecken Blackmore tube. If bleeding does not stop by banding and sclerotherapy or gluing, balloon tamponade should be tried. Most of the time, bleeding comes under control by balloon tamponade. So we'll see what is the method of balloon tamponade. First, the gastric balloon is inflated with 300 ml of air. So air is very important. It is not filled with liquid because in case balloon ruptures, the liquid should not be aspirated. Later, the esophageal balloon is inflated with air of 30 to 40 millimeters of pressure. This should be deflated for a short period of 12 to 24 hours so as to prevent necrosis of esophageal mucosa. Inflation of gastric balloon is most important. So in gastric balloon tamponade, inflation of gastric balloon is more important than esophageal. Esophageal balloon is inflated only if needed. X-ray is done to confirm the position of balloons. Usually 24 to 72 hours bleeding. Usually 24 to 72 hours are required for bleeding to come under control. And in meantime, resuscitative measures are taken. Success rate is good but only temporary. It should be followed by definitive procedures like banding and sclerotherapy. Rate of rebleed is 60%. Balloon tamponade is only a rescue procedure. So friends, we saw various non-surgical measures to control acute bleed. So now we'll see what are the surgical measures. Transjugular intrahepatic portasystemic shunt, or it can be stenting. It is used if all other earlier methods which are mentioned above, they have failed, which occurs in around 10% of acute bleed patients. So it is commonly used to control the uncontrolled acute bleeding and it will prevent further bleed. It will also act as a bridge to tide over the crisis and to prepare patient, or patient can be easily waited till the transplant is available. So friends, now we'll see other surgeries for acute bleeding. So acute variceal bleed, they can be also subjected to porta-azygous disconnection. So from this figure, we know that there is anastomosis between portal radicals and systemic venous component. So portal radical is being provided by gastric veins and systemic radical is by azygous veins at the lower end of esophagus for bleeding varices. So when you have disconnection of these both, automatically the bleeding varices will get controlled. So now we'll see which are the surgeries which are used to do porta-azygous disconnection. First is the esophageal stapler transaction and reanastomosis by Johnston. So it is stapler transaction at lower end of esophagus and reanastomosis in the same sitting. So this automatically transects the variceal component at the lower end of esophagus and bleeding will stop. So when patients present to you with acute variceal bleed, if all other methods are not helping and you don't have availability of tips, these patients can be subjected to transaction reanastomosis. Second operation is Borima-Kriles approach. So it is through thoracic approach. It is by transaction and reanastomosis and devascularization at the lower end of esophagus. Next we have Tanner's abdominal esophagogastric transaction. Likewise, Hassab operation deals with devascularization and splenectomy. So along with devascularization at the greater curvature and lower end of esophagus, you also do splenectomy. This automatically decreases the blood inflow from the spleen. We also have Sugiura-Futagawa operation, which includes vagotomy, pyloroplasty and devascularization along with splenectomy. So this is much extensive surgery which involves devascularization at the lower end of esophagus along with splenectomy, along with vagotomy and pyloroplasty. Shunt surgeries are not commonly used to control bleeding in acute stage. This is very important. you may be asked a question in which of the following surgeries are done or which are following surgeries are not done in acute variceal bleeding. So surgeries which are not done are shunt surgeries, and surgeries which are done in acute variceal bleeding are esophageal transection and reanastomosis. The names of the surgeries, as I have mentioned earlier, this should be remembered for acute variceal bleeding. Apart from all the measures to control acute bleed, you also should be treating the main disease. For that, you have to do liver biopsy to confirm the cause of portal hypertension. After you should be controlling PT. Before you control PT, you cannot do biopsy. Correction of clotting mechanisms by vitamin K, blood, plasma or platelet concentrate. You should be also controlling the encephalopathy by giving purgatives, that is lactitol or lactulose syrup. Patient should be put on protein-free diet, or also neomycin, which is non-absorbed through the GIT, can be given 6 hourly. Patient should be also put on parenteral nutrition to give him adequate caloric intake. So friends, we saw what are the acute managements of the varices. Thank you.